Welcome to the 339th of the COVID calls. This is a daily discussion of the COVID 19 pandemic with a diverse collection of disaster experts. My name is Scott Gabriel Knowles. I'm a historian of disasters at the Korea Advanced Institute of Science and Technology. I'm coming to you live from Daejeon, South Korea. Today, I welcome Peter Polos to discuss doctors with disabilities in COVID times. Just a reminder, you can usually catch COVID calls live on weekdays at 6 p.m. Eastern Time. Just go to the COVID Calls YouTube channel to watch. You can hear COVID calls anytime, recorded as podcasts on Spotify, iTunes, Podbean, or anywhere you get podcasts. You can also keep up with COVID calls via Twitter using the handle at US of Disaster or at COVID calls. Please do help spread the word and send suggestions for future guests and future topics. Please feel free to suggest yourself as a future guest. As of today, September 13th, 2021, there are 4,630,729 deaths from COVID 19 globally. That's according to the Johns Hopkins University Coronavirus Resource Center. I've been reading an obituary or a story of advocacy for those impacted by the pandemic, and I'd like to continue that now. The headline is Call for Urgent Action to Prevent Learning Disability Deaths. This was written by Ruth Clegg and appeared in BBC News June 12th, 2021. People with learning disabilities are still dying 25 years earlier than the rest of the population, a report has said. The Learning Disabilities Mortality Review, LEDER, calls for urgent action to prevent more avoidable deaths. Quarter of learning disability deaths were caused by COVID in 2020 compared to 13% of other deaths. The National Health Service in England said improving the health of people with a learning disability was a priority. The LEDER was established in 2015 to try to understand why so many people with learning disabilities were dying from avoidable causes and to try to improve their access to health care. The latest report compares data from the deaths of 9,110 people with learning disabilities who died over the past 3 years. It found that while there had been some small improvements, life expectancy had increased by 1 year. People were still experiencing huge inequalities. In 2020, 24% of learning disability deaths were caused by COVID-19 compared to just 13% in the general population. Peak month for deaths from COVID-19 was April of 2020, when 59% of all deaths were from the virus. It was the leading cause of death in men over 35 and women over 20 with learning disabilities throughout the past year. Reviewers found that poor testing provision, a lack of support from specialist services, and difficulties using the National Health Service 111 line service played a part in many of the deaths. Nearly a third of do not attempt cardiopulmonary resuscitation orders made in relation to people who had died from COVID-19, the correct procedure was not properly followed. In some cases, the reason given for a do not resuscitate order was because the person had a learning disability. One example cited in the report was because the person was wheelchair bound, needs to be hoisted, care home resident, learning disability. They also found many examples of poor care. In 42% of the deaths in 2020, reviewers felt that the person's care had not met good practice standards. Stephen Baskin's family feared that he could have become one of those statistics. The 43-year-old who has Down syndrome was treated in hospital for COVID-19 at the beginning of the outbreak in March 2020. His father, John, was told that his son would not be given access to a ventilator should he need one because of his underlying health conditions. He said, "I received a call from a doctor who told me that a decision had been taken. Should Stephen require the use of a ventilator, then this would be denied. I was exercising in the park at the time of the call and had to find a bench to sit down. I was really taken aback." He discussed Stephen's condition with other senior doctors who intervened, and the decision not to give him a ventilator was reversed. He said Stephen had undergone treatment which affected his immune system, but other than this, he was perfectly healthy and his treatment was going well. Stephen recovered from COVID-19, but his family felt they had to fight to get him the access to health care they felt he needed. Report author Pauline Heslop, who is based at the University of Bristol, said this year, for the first time, we've been able to compare data based on the year of a person's death. There are some small signs of progress being made, but this is not sufficient, nor sufficiently well distributed across people with learning disabilities from different ethnic groups. Actions taken to date, while welcome, have clearly not been enough to make the progress we should expect to see. Claire Murdoch, mental health director for NHS England, said every year people with a learning disability die sooner than they should, and many from potentially avoidable conditions, such as constipation or aspiration pneumonia. Despite the pandemic, the National Health Service has ensured that three-quarters of people over the age of 14 with a learning disability have received their annual health check 2 years ahead of the long-term plan target, she said. It's vital that we use this report to make real and lasting change to help close the health inequality gap seen throughout society. Okay, I'd like to turn to the conversation and let me introduce you to my guest today, Dr. Peter Poulos. Peter Poulos is a clinical associate professor of radiology and gastroenterology at the Stanford University School of Medicine. In 2003, as a GI fellow at UC San Francisco, he suffered a spinal cord injury and subsequently retrained in radiology. His specialty is body imaging, focusing on CT, MRI, and ultrasound of gastrointestinal diseases. He is the founder and co-chair of the Stanford Medicine Abilities Coalition. He's a member of the School of Medicine Faculty Senate and the Stanford Medicine Diversity Cabinet. His work focuses on advocacy, education, and health equity for those with disabilities. He is the co-host of the Docs with Disabilities podcast. Peter Poulos, thank you for making time to join me on COVID Calls today.
Good to meet you, Scott. Thanks.
So I'd like to start the way I generally do, just find out where you're calling from and get a snapshot of what the COVID situation looks like there today.
Yeah, so I'm calling from my home in San Carlos, California. We're in San Mateo County in the Bay Area. Things are not great here with Delta raging, but it's not as bad as it once was, of course, during the peak in January. But hospitalization rates have been decreasing slightly, but ICU admissions have been on the uptick. And so Stanford right now is currently in the process of building up some more surge capacity in anticipation of those patients. But, we have less than 20 patients right now in our ICU. And so, that's considerably better than before. Santa Clara and San Mateo County are somewhere between 80 and 90% vaccinated at this point. And so I think that's a big reason why we're doing so well and better than other parts of the state and country that have lower vaccination rates.
This surge that you're describing, how many times is that for you at your medical center?
So we surged up at the beginning of the pandemic, preparing for a surge that wasn't quite as bad as we imagined, thanks to quick acting by the California government and shutting things down and flattening the curve. And then we had another surge in the winter, and I think this is a third surge at Stanford, although I'm not directly involved in those decisions or surge planning, so I could be wrong about the exact number, but that's my understanding.
I wonder if you wouldn't mind sharing a memory of this period. And I always say this because it's kind of an impossible task. There's such a density of memory in these last year and a half and more of the pandemic. But I wonder, is there something that really resonates for you about this time?
Yeah, so there are a few memories. This has been a really poignant time. And I remember the first, we'd been hearing about coronavirus for, at least a few weeks before things were shut down. And I remember thinking, oh, this isn't likely going to be a big deal, and just sort of pushing it out of the back of my mind. But when things really started to get serious, I got fearful for myself. I have poor lung capacity, and it's difficult to breathe because of the diaphragmatic and other muscular paralysis. But I don't use a ventilator or anything. But I knew that if I got COVID, I would have a tougher time fighting it than someone else. And so I guess my first instinct was sort of self-preservation and acting by just sending an email to my leadership asking if I could work from home, and they were immediately okay with that. And then shortly after, they're thinking about like all of the other people with disabilities out there, not just in medicine, but of course our patients with disabilities. And so that was my initial thought. And then just thinking about in general, like my caregiving situation and like what would it mean to be socially isolated with just like me and my wife at home. Like I have caregivers who come into the house and help me, and what to do with them. Luckily, they were socially distancing and kept coming into work and providing care, which was like essential basically for my continued function. And I knew that other people probably, weren't so lucky, and so it just brought up all of these different different issues related to disability. And then there were a couple other things that happened too that were pretty crazy. One was my son was born on July 26, 2020, and my wife became quite ill after the birth and needed to be transferred to the ICU. Like nothing to do with COVID, just a pregnancy complication. But she was separated from the baby, and on account of, I mean, that was very traumatic for her. But they, just because she was in the hospital didn't mean that they were going to keep the baby there, and so I had to take the baby home, and this is something I did not plan on. And so again, like luckily I was able to cobble together some care for myself and for the baby. So just thinking about disability and parenting and how that thing goes. So yeah, there were quite a few twists and turns.
Thanks for sharing those stories, and congratulations on your now over 1 year old new member of your family. That must have
Yep.
been in the midst of all of that, what's already a stressful thing when everything goes exactly to plan. And I hope your wife is okay,
Yeah, she's
and
fine.
I'm
Thank
glad
you.
to hear that. And then uh, to say, okay, it's time for you, Peter, to take your child home. That must have been really something.
I did not plan on this. I mean, we had talked, I mean, being disabled and a parent is complicated. And, I wanted to be as involved with the parenting as I could be. But we had to decide amongst ourselves, like what that would look like and how much I would actually do just as a matter of like efficiency and practicality. And so, we had not decided that I would be like the single caregiver. So yeah, it was quite a shift. But like I said, I mean, luckily Diana had some things in place, like a night nanny before the baby was born. So, and my caregivers really stepped up to the plate and took care of me and the baby. And so luckily they've been working with me throughout the pandemic. Neither one of them has gotten COVID. We haven't gotten COVID. But I've been working at home the whole
Mhm.
time also, and my wife hasn't been working. So we've been able to socially isolate pretty well also, which has been a real benefit.
One of the things I wanted to follow up on there, and I've read about it, but hadn't heard from someone firsthand about in-home health caregivers and the protocol. So pre-COVID, I mean, did you already have sort of more stringent health protocols with with health workers that come into your home? I mean, COVID is not the only thing that could make you sick at home. And as you said, if you have some uh, uh, heightened vigilance for respiratory disease, it seems like something you would have already maybe be attentive to. I ask this because the reporting I've read is to the extent that it's reported, it does seem that that's been a huge issue for people with disabilities, is the coming and going of healthcare workers who are going from site to site to site throughout their day and throughout their week, and early on may not have had access to the appropriate PPE or the knowledge that they needed to keep their patients safe. So I wonder how that's worked out for you.
Yeah, so that you would think that one might have protocols, but no, I don't, other than, please wash your hands when you come in the door. Um, no, these are private caregivers. They don't come from an agency. I mean, we follow, standard procedures, but there's really nothing that needs to be sterile necessarily, or much in the way of even like medical procedures. And so, no, we don't really have anything other than, they'll call in sick if they're not feeling well.
Well, that alone is
But I'm lucky, and the women who work for me are like very smart and responsible, and caring, and also themselves, their own personal situations are such that they don't have significant others who are seriously exposed, nor do they have like a lot of people coming and going, or lived in a multi-generational household, for example. And so there were a lot of things that we're lucky about this situation.
Just a reminder, you're listening to COVID Calls, and I'm talking with my guest, Peter Poulos, about doctors with disabilities in the COVID-19 age. And Peter, let's go back, if we can, and talk about your work before COVID. Any part of that in your bio, it describes injury in 2003 and how that changed your life, and your advocacy work, which has been ongoing, it seems like, since then, all the way up to the time of the pandemic. And then we'll talk about the pandemic after, but I'd like to get a little backstory.
Yeah. So, do you want me to go back to like when I was deciding whether or not to change careers?
Absolutely.
Oh, okay. Well, yeah, like you said, I had a spinal cord injury in 2003, and I was paralyzed initially almost completely from the neck down and unable to move. Luckily, my injury was incomplete, and so I did gain function back over time, regain the ability to walk slowly and some movement in my arms. It's nowhere near back to normal. Like if we were in person, it's pretty obvious that I have a disability. And I was excited to get back to work and get back into the hospital and start seeing patients again. And seeing patients was really great. I felt like I had a new perspective on the doctor-patient relationship, a lot more, not just empathy, but connection. And, that was wonderful. But at the same time, it was very difficult for me to examine patients without help. The procedures that I loved to do, I wasn't able to do anymore. And, I also felt like I had fewer options in gastroenterology than I would have in radiology, in terms of like a practice setting. And so in thinking about radiology, I thought, well, if I ever worsened substantially, I could work from home, never thinking that I would end up working from home because of a pandemic. It's like
Right.
the society collapsed, but not my own health. And so, but I knew that could be a benefit in different situations. And the best part would be I'd be able to do the work without any assistance. So when I'm at my computer, I have a mouse and a microphone and the standard software everybody else has, and I'm able to do the work and able to do it at a speed and volume that's similar to my colleagues. And so, in medicine, I think experience is one of your best teachers. And so to be able to see more patients and take like a normal volume of work and work experience was really important to me. And so, yeah, I decided to make the switch to radiology and started at Stanford in 2004, and then did 5 more years of training there and started on the faculty in 2009 in abdominal imaging. So just taking it back to those GI diseases that I found interesting, ever since medical school. And so my practice was pretty much like a standard academic practice, um, similar to my peers. You mentioned the modalities of imaging I read, and I just spend most of my time, at the computer with a resident or fellow, going over cases with them, pointing out either findings that they missed or confirming their findings, discussing, ways in which we might craft our report and better, communicate illness or health to our referring providers. And so, I do have some accommodations because of my disability. For example, I don't take any overnight call or evening call. That's one thing. And I have a backup person when I am on call to do procedures in case one is needed. But that's about it. And then, around, well, I would say in the beginning of my career, I was focused quite a bit on administration of the residency program. I was the associate program director for 7 years. And I stopped doing that in 2016 or 2017. And then decided that it was time to look for something else, some other way to make an impact. And I noticed that disability wasn't being represented in all these great diversity efforts that were going on around campus, or if they were, I wasn't aware of them. And so I decided to get involved. I'd always had an interest in like social equity and social justice. And so, so I joined my department's diversity committee as, a disability representative without really any goal to start any disability related projects, just wanted a seat at the table. And then from there, joined the faculty senate subcommittee on diversity, and very sheepishly brought up the idea that maybe we would work on a disability related project, which I was surprised that people were enthusiastic about taking on. Of course, as the person with the disability, I became the person in charge of the effort. And at that time, I really didn't know much about disability at all at Stanford or disability advocacy in general. It was like a very steep learning curve, mostly because I'd been treated so well, and have so much like privilege as it pertains to, my access to healthcare, my caregiving situation, my stable family life, my income, and understanding leadership and colleagues. And it wasn't until, I started the Abilities Coalition that I started to hear the stories and realizing that, it wasn't all roses anywhere.
Let me follow up on the medical education side of things. So, either in your experience or in what you've come to learn now in your advocacy work, what what is the reality of life for medical students with disabilities? And it's a wide spectrum, right? I mean, so we could be
Mhm.
talking about everything from learning disabilities to mobility disabilities, chronic health conditions. So it may not be a very take any part of that you want to, but I'm curious specifically how things may have changed if they have for the better, or hopefully not for the worse, in the time that you've been following this. What's it like for a medical student with a disability these days?
Yeah, so I would like to think that we have made an impact at Stanford. Um, there's a disability community. Well, there was a disability community there for the medical students even before I started SMAC. So the medical students formed a group called MSDCI, Medical Students with Disabilities and Chronic Illness. And they formed a few months before SMAC was formed. And they were actually instrumental in really educating me on the disability situation, and in sharing their stories so generously really contributed um, to my ability to convey the importance of this issue. Since, like I said, I didn't have my own personal experience with mistreatment. So I would say that the experience for medical students in terms of community has definitely improved in the last few years. They have each other, they have SMAC, they have advocates amongst like the faculty who are looking out for their well-being. But the experience is highly variable. Um, as you can imagine, it depends on whether or not somebody has a visible or invisible disability. I think that the people with visible disabilities, especially like mobility or wheelchair users, tend to have an easier time accessing accommodations and being taken um, at face value and believed that there is a reason that they're requesting for accommodations, whereas those with other less visible disabilities or chronic health conditions often meet more resistance or skepticism when asking for accommodations. And so, I mean, just from the very start of even thinking about being a doctor, all the way to practicing medicine, there are barriers along every step of the way. So, I mean, and just put aside all of the barriers that a person with a disability encounters before medical school in terms of their education and livelihood and experience, and assume that they have the the grades and the scores and the social situation that would enable them to start as a medical student. Well, then they go on to the internet and start doing research about what it takes to be a medical student. They'll encounter these things called technical standards, which are sort of non-academic requirements for completion of a medical program. Things like, um, you know, you have to be able to do cardiopulmonary resuscitation. You have to be able to listen to heart sounds or read an X-ray. Um, so a lot of these are put in terms of like functional type language that if you if it's not explicitly stated, which it often isn't, that this can be with or without a reasonable accommodation, a person with a disability would look at this list and think, well, there's no way I can do this. Schools have different approaches to how they enforce the technical standards, and some are better than others about um, using reasonable accommodations to accomplish the same objective. For example, if to perform cardiopulmonary resuscitation is a requirement, some school might take that literally, that the person has to do it themselves, whereas another school might say, well, a physician is rarely going to be the one to be doing the CPR. And even so, he has a team of nurses and other people, so we'll allow them to explain the process of CPR, or schools have developed tools to allow even a quadriplegic person in a wheelchair the ability to do chest compressions to fulfill the technical requirements. And so that's a big hurdle. And then, in applying for medical school, let's say they're granted an interview, the interview letter may not say anything about asking them if they need accommodations.
Right.
If they get in, there's no information about how to request accommodations. Maybe there's no welcome inviting people to disclose whatever disabilities they might have. So there's like a real lack of proactivity on the part of many medical schools. And then there's the fear of disclosure and what disclosing a disability will do to their reputation and their future career plans, and what sort of discrimination they may or may not experience. And then there's the way any accommodations they may receive are received and implemented, which can be anywhere from happily to very unhappily or not at all. So there are problems all along the path.
I just want to remind everyone that you're listening to COVID Calls, and I'm talking to Peter Poulos today. And thanks for going through those. I mean, there's so much to work on there, and that's just in terms of medical education. And as you said, I thought that's just at the point of like trying to get into medical school and get through those years, not everything that came before. So I want to pivot to something you wrote earlier in the pandemic. One of my guests the other day said historians have already started talking about the pandemic in periods like the early pandemic, the mid-pandemic, and it's true. We do have that sense of it. You wrote a piece in the online publication Just Security this was in April of 2020. The headline was "Healthcare Workers with Chronic Illness on Coronavirus Frontlines: The Need for Accommodations." I'm just going to read a sentence of it. It's a really powerful piece that you wrote. You said, "I consider myself strong and resilient, having lived through the experience of rehabilitating and rebuilding my life after my accident. I'm also generally healthy. I do not have chronic illness, but my injury weakened my diaphragm and respiratory muscles in addition to my arms and legs. So I have diminished lung function and a persistent feeble cough. That means I would have difficulty fighting coronavirus and more difficulty weaning off a ventilator should I need one." And this is what you were describing this, earlier in our conversation. You go on in the piece to talk about the many different experiences of healthcare workers with disabilities and the call in that moment to make sure that they have the protection they need, especially, and you described a situation where you could work remotely, but that's not been the case for healthcare workers, doctors, nurses, and support staff in many settings. So I wonder, maybe talk a little bit more about what motivated you to write this and what the impact has been, what you've seen, maybe hopefully in reaction to that call.
Yeah. So, right after I made arrangements to work from home, started, talking to friends of mine in the medical field. And one of my friends, he's a radiology resident back east, told me that, and he's immune suppressed, actually, and confided in me about the nervousness that he had about going to the hospital. And, he tried to talk to his residency program director about his request to work from home, and was sort of met by, again, skepticism and hostility. The program director was sort of putting it in the guise of that it would be in his own career benefit to stay and work in the hospital, because if he didn't, people would really question his motivation for becoming a radiologist and his dedication to the program. I mean, this was stated explicitly. And and by the way, only the faculty have the ability to work from home. You see, we have these special workstations, but we couldn't possibly provide those for the residents. That would just be too much. And if we give them to you, then everybody's going to want them. These typical sorts of discussions around disability about opening, a can of worms. And so, he ended up like really not getting much in the way of accommodations. Eventually, let me rephrase. In the beginning, he did not, but then uh, pretty quickly after that, they, like a lot of other programs, told everyone that they could work remotely. And so he sort of got absorbed into that everyone category. And that's how things resolved. Not because they made any exception for him, but because they realized that this was the right thing to do for everyone. And then I talked to another friend of mine from San Francisco whose supervisors basically told him to, suck it up. That he was a physician during the AIDS crisis, from the very beginning, and they're like, you know what to do with infectious disease. Wash your hands, gown up, and you'll be fine. And really, just sort of dismissive attitudes like that. Telling people not to worry about it. And so this is what motivated me. I mean, these are just two people that I talked to. I figured that later I would talk to a few more people, but I knew that this would be an issue affecting tons of people. And beyond physicians, but to nurses and respiratory therapists and any other healthcare worker in the hospital or even outpatient setting. And so I don't know how much of an impact it had. I don't know if this has been studied or not at this point, but I would like to think that it started a conversation. I know that it did have an effect at Stanford and really brought this to the attention of like our leadership, who hadn't been really thinking about that up to a point. But the problem is that, just because you're making people aware of something uh, you know, and just because leadership of an institution is enlightened about these things doesn't mean that accommodations or the right thing is going to be done at the individual level. Because so many people with disabilities like report, one level up in their organization to ask for accommodations or work modifications. And that means that the system for a lot of people is very decentralized, and that it can almost be random as whether or not your supervisor like has any knowledge of laws or regulations around disability, whether or not you receive the help that you need. And so, of course, like, people do have a right to go to HR and invoke their rights under the ADA, but there's such a stigma and fear around this that people often don't. And their nursing supervisor or ward administrator, whatever, may not have the necessary skills or willingness to make these things, and sometimes it just stops there. And so that's a huge problem, and that is has to be tackled through like continued education and advocacy on one hand, but also just like better processes and
Mm.
and structure for so people with disabilities know where to go for help, because it's often the case that they don't.
I wanted to follow up on that because I've talked with lots of disability rights advocates throughout the pandemic, and there's been this sort of sense that this is a moment, maybe the only moment we've had, where across the entirety of American society, the term accommodation has been heard. And people, and mostly for people without disabilities. Like, we need to make an accommodation so you can work safely during the pandemic. And there's a deep, terrible irony in that, and yet a possibility, as has been pointed out to me, that this is once again a moment where people who don't think much about disability have had to look at that and think about what that means. And so, just to follow up on what you were saying, I mean, what's the right scale for intervention for health providers, for doctors with disabilities in this moment? Is it just, you were describing the problem, you have to report one level up for accommodation? I mean, is it in training? Is it in the way health system managers are trained? Is it more on the legal side? So there should be state laws that actually dictate what needs to happen. I'm just sort of curious your sense of where you pick this problem up if you really want to intervene in this moment of, I mean, opportunity isn't the right word, but in this moment of possible change. Where's the action point?
Yeah, well, there's a lot of potential action points, but I do think that a top-down approach has to be undertaken to enact significant change in the system. I mean, the Americans with Disabilities Act and Section 504 of the Rehabilitation Act made a huge difference in the lives of people with disabilities who had been advocating for years for equal treatment under the law. And for years, we're told that it wasn't necessary, that people really, that people are good and they wanted to make the right accommodations and do the right thing. And it wasn't until things were codified into law that we really started to see any movement in that direction. So, I think that the regulatory bodies in medicine are going to play a big role in this. So, the Liaison Committee on Medical Education that accredits medical schools, if they start to require that disability is routinely tracked as a function of diversity measures, if they insist that schools have to show what they're doing to attract and train and retain students with disabilities, if they are required, if schools are required to show proof that they are including disability education about patients with disabilities in their curriculum, I mean, those will make a huge difference. And similarly with the American College of General Graduate Medical Education, the ACGME, I may have bungled that, which is really embarrassing. But they govern all of the rules and regulations for residents and fellows, and then the AMA. I mean, we're talking to all of these people. Myself and other people working in this field are talking to these national bodies, and they're the ones who are going to have to hold hospitals and training programs accountable for what they're doing. And so I do think it's going to take that. I mean, we talk a lot about culture change and education, and this stuff is really important, especially like in improving the climate in an institution. But I don't think things are really going to change until they're mandated by regulations and laws.
With that on the table, I wonder about what your vision is of inclusion and the impact of that across the health system more generally. And I think about that particularly in this time of COVID. If this work maybe had started 25 years ago, if somehow health outcomes with COVID might have been better more generally, fewer healthcare workers, just in those situations that you described. I mean, this is something that it starts pretty far upstream, I think. But, we're talking about disability advocacy, but that has, in my experience, that has impact for everybody in the health system, not just people with disabilities who profit from that kind of inclusion. I wonder if that's something that's a case that you've been able to make.
Yeah. So, I mean, Yes, it has to start. I mean, it has to do with the whole health system in general, but especially around social determinants of health and getting all people better access to healthcare that's, comprehensive and affordable. And then just training healthcare providers how to take care of patients with disabilities. We need more research into like best practices for taking care of patients with disabilities. There's emergency preparedness, making sure that information is in an accessible format for patients and their families. Accurate reporting of how many patients with disabilities are we serving and how are we doing serving them. That kind of information is not being currently collected. And so, I mean, if you're not counting people, then there's no way to know where you are and there's no way to improve. And so all of those things need to be done, and they need to be done not only for people with disabilities, but for those in other marginalized groups.
Mm-hmm. We're almost up on time in my COVID calls conversation with Peter Polos today. And just on the way out, Peter, I wanted to give you a chance to give a plug for your podcast, Docs with Disabilities, and your co-host, Lisa Meeks, who's not with us today. We hope to have her on a future COVID calls. What's the podcast about?
So the podcast is called Docs with Disabilities. We interview not just docs with disabilities, but nurses, physical therapists, OTs, other healthcare providers with disabilities, and also our allies in the disability space about their personal experience and their ideas and research about disability in medicine. Lisa started the podcast a couple of years ago, more like 3 years ago now, and I joined her as co-host in January. And we're going to be soon starting a special series examining the lives of BIPOC people with disabilities and the intersections between race and disability. And so that should be coming out shortly. I think it's just for anyone who's interested in healthcare and disability, this would be a great resource. I think one of Lisa's main motivations for starting it was as what she calls an asynchronous mentoring tool that people who are interested in getting into the medical field or who are in it now with disabilities can go and use it as a resource and find people like them who are talking about what it's like to live with a particular disability while in school or beyond.
Just want to remind everyone you've been listening to COVID Calls, and you can catch COVID Calls live most weekdays at 6 p.m. Eastern Time. And today, please stay tuned. There'll be a second COVID Calls episode starting in just about 10 minutes. I'll be talking with sociologist of risk, Dana Fisher. So please do join me for that. And I want to thank my guest, Peter Polos, for this really enlightening conversation. Peter, thanks for making time to talk to me today on COVID Calls, and good luck with your continued advocacy in this really important time.
Thank you.
Stay healthy, everyone. We'll see you next time on COVID Calls.